Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on JCO article, a Phase 2 study of the MEK1/MEK2 inhibitor trametinib, GSK 1120212, in metastatic BRAF mutant cutaneous melanoma patients previously treated with or without a BRAF inhibitor by Kevin Kim and colleagues. My name is Keith Flaherty, and I'm the Director of Developmental Therapeutics at the Massachusetts General Hospital Cancer Center in Boston, Massachusetts. My oncologic specialty is medical oncology with a focus on skin cancers. Following the identification of activating mutations in BRAF isoform kinase, also known as BRAF, in 2002, in approximately 7 to 8% of all cancers and 50% of advanced melanomas, multiple lines of evidence suggest that mutated BRAF is a critical contributor to melanoma pathophysiology. In 2009, the first responses were documented among patients with metastatic melanoma harboring activating BRAF mutations who were treated with vemurafenib, the first orally available selective BRAF inhibitor to enter clinical development. This agent was subsequently shown to be superior to chemotherapy in a Phase 3 trial, leading to FDA approval in the summer of 2011. It has long been known that BRAF directly activates mitogen-activated protein kinase, also known as MEK. Before selective BRAF inhibitors were successfully developed, responses had been observed in BRAF mutant metastatic melanoma patients treated with orally available selective MEK inhibitors. However, the response rate and overall disease control observed in early trials did not support Phase 3 investigation. Trametinib represents the first of these selective MEK inhibitors to show a sufficiently high response rate and apparent prolongation in progression-free survival in Phase 1 testing to warrant further investigation. The Phase 3 clinical trial, published in the New England Journal of Medicine in 2012, recently demonstrated that trametinib produces superior progression-free and overall survival in comparison to dacarbazine or paclitaxel in the treatment of BRAF mutant metastatic melanoma. The Phase 2 trial, reported by Dr. Kim and colleagues, that accompanies this podcast, provides several important insights that have not previously been clear from the Phase 3 trials of either vemurafenib or trametinib. The trial comprised 2 cohorts, 57 patients who were BRAF inhibitor naive, who had previously received 1 or more systemic therapies for metastatic disease, and 40 patients who had received a selective BRAF inhibitor previously, in addition to other systemic therapies. The BRAF inhibitor naive cohort demonstrated a response rate and progression-free survival that was consistent with those endpoints in the trametinib Phase 3 trial, even though the patients in this Phase 2 trial were permitted to have received multiple additional lines of therapy for metastatic disease. These results corroborate the notion that BRAF or MEK inhibitor therapy can exert a similar impact when used as a first or subsequent line of metastatic treatment, provided that no BRAF or MEK inhibitor has been previously administered. This addresses a particularly important clinical practice issue. Recent advances in melanoma immunotherapy have led to the approval and adoption of ipilimumab, the CTLA-4 blocking antibody. Additionally, high-dose interleukin-2 remains a standard therapy for a selected subpopulation of metastatic melanoma patients. The results observed by Dr. Kim and colleagues supports the maintained efficacy of MEK inhibition in patients who had previously received immunotherapy. An additional important finding when the BRAF inhibitor naive cohort was objective responses in 2 patients with fairly uncommon BRAF mutations. The vast majority of BRAF mutations found in melanoma affect the valine amino acid at the 600 position of the amino acid sequence, with so-called V600 mutations being significantly more common than V600K mutations. The Phase 2 trial reported by Dr. Kim and colleagues included one patient with a 601 position mutation and one with a V600R mutation identified upon centralized BRAF gene sequencing. As Phase 2 and Phase 3 clinical trials with vemurafenib and the Phase 3 clinical trial of trametinib restricted eligibility to those with V600E or V600K mutations, relatively little is known about the efficacy of either BRAF or MEK inhibitors in patients with lower prevalence BRAF mutations. The observed responses in these two patients in the present trial support further investigation in patients with rare BRAF mutations. Importantly, in non-small cell lung cancer and other tumor types, some of these BRAF mutations are found with higher frequency. The results observed in the BRAF inhibitor refractory cohort are a particularly important contribution of this study to the medical oncology field. With vemurafenib as an available treatment option for patients, practitioners are confronted with the challenge of determining what treatment options remain following disease progression on a BRAF inhibitor. Laboratory analysis of patient tumor samples has previously shown that MEK activation is restored in most patients at the time of disease progression on a BRAF inhibitor. This observation supports the investigation of a MEK inhibitor in BRAF inhibitor refractory patients, with the hope that this therapy could effectively salvage patients in that clinical setting. Unfortunately, no objective responses were reported in patients who were BRAF inhibitor refractory, and the median progression-free survival was 1.8 months, comparable to historical standards with relatively ineffective systemic treatments. The only two objective responses observed were in patients who had previously discontinued BRAF inhibitor therapy due to toxicity and not due to disease progression. Taking the results presented in this Phase 2 trial with the recently published Phase 3 trial results, one can readily conclude that MEK inhibitor therapy is an efficacious strategy in metastatic melanoma harboring and activating BRAF mutation. However, in light of the current availability of vemurafenib and the data presented in this trial showing a lack of efficacy with trametinib in BRAF inhibitor refractory patients, it remains unclear how a MEK inhibitor should best be used in current clinical practice. In that regard, a significant amount of attention has been given to the investigation of combination regimens of a BRAF and MEK inhibitor. Preclinical and early clinical evidence suggests that these two types of agents can be safely co-administered and potentially improve the durability of responses in comparison to recent historical data with single-agent BRAF inhibition. The results of randomized data comparing BRAF and MEK combination therapy to single-agent BRAF inhibitor therapy are eagerly awaited. This concludes this JCO podcast.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.